the recording. Okay, Mark.
Good. I have to acknowledge that it's being recorded. Creating that. It was the same on mine. It's funny, it doesn't give you your. Okay. So good morning, everybody. Sorry for the technical difficulty. So we're going to just discuss some first principles of non-invasive evaluation of coronary artery disease, describing some of the anatomical, functional, and clinical aspects of this. And forgive me if this is such a basic level as to be rudimentary, but I think there is something to be learned in the process, hopefully. So no conflicts. We're going to talk about applying cardiac imaging, stress echo, perfusion, and CT. So just a brief discussion about coronary artery disease. We all know that this is a multifaceted condition. You have anatomical remodeling, stenosis, and then punctuated by acute clinical events. And because of the dynamic nature and chronicity of this lifelong predisposition, the clinical manifestations are often, well, they're frequently quite disparate. You can think of it as two phenotypes, principally stenotic and non-stenotic, and the stenotic tends to be fibrotic and stable and manifests with angina, abnormalities on stress testing, and can be revascularized, whereas the non-stenotic phenotype can often be first presentation as a transmural infarct. And unfortunately, when you think of this, the stenotic lesion is like a kinked pipe or a blocked pipe. It's often, you've got plenty of lead time, whereas the non-stenotic phenotype, by analogy, is like a saucepan of popcorn kernels. And the treatment is to turn down the heat and try to stabilize with medical therapy. So unfortunately, the non-stenotic phenotype manifesting as thrombotic occlusion is often more sinister clinically and unpredictable and often highly morbid. So when you're trying to determine an answer, it's good to start with the right question. So what's the best approach in assessing non-invasively coronary artery disease? Is the question, are we asking about detecting the disease versus managing it? Are we describing diagnosis versus prognosis? And are we describing anatomy versus function? Because as we'll see, the different modalities speak to different aspects of this condition. So I'll start with a case. This is a real case that I encountered in my practice earlier. A man below 50 years of age, a physical education instructor who complained that he was becoming more breathless with exertion, and he wasn't sure if this was just the progress of age or whether it was coronary artery disease. He did have coronary disease in his family, father with CAD at a younger age, some risk factors, mildly hypertensive, high triglycerides. So he's referred for an exercise test. He accomplished almost 13 METs on the Bruce protocol. He had mild dyspnea, which was reproducing the symptoms that he had, that he complained of originally, but objectively was more fit than most. Mildly hypertensive exercise response, and he did have a positive ECG response. So what would we do? Well, would we reassure him? Would we treat him medically with primary prevention? Would we do an advanced imaging? I don't have a face-to-face, but if anybody in the audience would like to shout out a decision, feel free. I'm assuming you're all answering at once and jamming the system. That's the reason for the complete silence. Well, just going into first principles, there's the notion of the ischemic cascade. So somebody would do a stress echo. Yeah, thanks, Sharif. So the ischemic cascade really goes, if you think of on the horizontal axis, the exposure time mismatching oxygen supply and demand, acute to prolonged, and then on the vertical axis, looking at progressive manifestations of ischemia. So things like an abnormal stress test or repolarization changes, that's a manifestation of both prolonged and severe ischemia, whereas endothelial dysfunction can happen silently for decades. And the different types of tests address different aspects of this ischemic cascade. As alluded to, ECG changes are a late manifestation versus wall motion being a somewhat earlier in the cascade, and then perfusion occurring earlier. This does speak to some of the utility of the different modalities. When you think about a test, of course, the Bayesian theorem here, looking at application of pretest probability and then the diagnostic performance of the test, the most utility is in the middle, where you have an intermediate probability, and then you can recategorize these patients. Whereas if somebody has an extremely high probability, then you're unlikely to change your post-test probability. And similarly, on the other end of the spectrum, performance of the test will be attenuated because of the pre-existing probability. You're probably aware that there's been a campaign in the United States called Choosing Wisely, and Canada got onto this. And we should be thinking, how will this information, what tests that we use, how will it change health behavior? How will it change management? Is it cost effective? Is it worth the risk? So as was suggested, he was referred for a stress echo. And of course, this is like any imaging modality. You're having a resting state, a stress state, exercise or pharmacologic. And this is an example of an abnormal with a LED territory regional abnormality. This is not the patient stress echo, just FYI. It's cheap. It's not dependent upon repeated doses of radiation. It's quite specific, but it has some disadvantages, including insensitivity to posterior circulation ischemia. If you have a non-diagnostic stress, it becomes a non-diagnostic test. So make sure that you achieve the goal. Ideally, you'd have a rule-in scenario because it's a fairly specific test, etc. So he did, again, 12 minutes and had ECG abnormality, and the stress echo was normal. So what will we do now? Well, in the interest of time, he had ongoing symptoms, and he was then referred on for perfusion imaging. And the perfusion imaging, again, this is not his image, but it's trying to identify earlier in the ischemic cascade perfusion abnormality and various stressors. Stress perfusion has some advantages. It's very sensitive. It's quantitative. It's helpful with pre-existing coronary disease and existing wall motion abnormalities, perhaps a little bit less operator dependent. It has other disadvantages. However, it's quite expensive. There's a cumulative radiation dose, and you can have attenuation artifacts, which can create false positive. Special application. There is a very extensive literature on prognosis. It is applicable to known coronary disease with reasonable operating performance. If you have a left bundle branch block, then you should do a pharmacological stress lest you have a spurious perfusion defect involving the septum related to LVBV and exercise stress. And again, if it's an inadequate test, it's inadequate stress, it's a non-diagnostic test. This is good for rule out because it's very sensitive and intermediate body habitus, and I wouldn't be doing it serially. Just to speak about radiation dose, this is looking at units of absorbed dose over time. So if you were on the right side of the scale, if you're an atomic bomb survivor, not many patients are in that category any longer, but hopefully that's 200 millisieverts. Whereas if you have a single chest X-ray, that's 0.02 millisieverts, which is incidentally about the same as a transcontinental flight on an airplane. And a single dose of X-ray is about 0.04. Now, the notion being that there is no safe dose of radiation, but I have, unfortunately, in my practice in Toronto, I've seen nuclear scans being applied to 20-year-olds with atypical chest pain. And I would say that in my mind, that is indefensible since we have alternatives. So he did have a nuclear scan, again, this ECG positive, and the scintigraphy volumes and perfusion in stress and rest were normal. So what do we do now? Somebody said an angiogram. Well,
I was going to go there first, but I'm biased.
Well, Dr. McGrath actually had him in the cath lab before shaking hands. So if you look at the prognosis, this is survival curves for dobutamine stress echo on the left and perfusion imaging on the right. If you have normal stress echo and normal perfusion imaging, your survival is excellent. It's not a certificate of immortality. I have had many requests from patients to provide that, and I have not yet been able to do one that proved to be durable. But the prognosis is good. And so both stress echo and perfusion imaging are very, very good tests to predict prognosis. And this is follow-up. Notice the scale, it's years, 16 years. So it's a very, very good prognosis if you have normal stress echo imaging as well as microperfusion imaging, but not in mortality. So, the case went on and the patient had ongoing symptoms. At this point, I had been consulted after he had already had 2 modalities. And I had a discussion with him and I said, well, you have ongoing symptoms, abnormal stress, ECG response, the perfusion is normal, the stress echo is normal. Let's decide whether you have coronary artery disease or not. And let's do an anatomical test, which was CT angiography. And you all know that CT is the gold standard for coronary anatomy other than a coronary angiogram. It provides outstanding anatomical definition. You can determine the presence of atherosclerotic plaque. It is in segment by segment. It performs better than the functional tests. But of course, it's an anatomical test, and you can get into situations where you find CAD, but you're not sure if it's clinically significant. It has less operator dependence. It is relatively expensive, involving radiation as well as contrast. It doesn't provide functional information, and you have to have reasonable heart rate. So in hospital, for example, as a test to be applied for somebody who's tachycardic, it will have poor performance. So you have to be able to slow them down, give them nitrates, etc. So ideally, bradycardia rule out scenario, not previous metal in the coronary circulation, not extensive calcification, and I wouldn't be applying this serially. So, thinking about these 3 different modalities and like, what's the best first test? It's really a challenging question. Which population are you studying? I've seen research looking at renal transplant candidacy. So if somebody's got renal failures on dialysis, that's a different population versus the general population. Is this an academic core lab versus application to a variety of clinical environments? And then, of course, upstream from the clinical outcomes that matter to patients, you have the initial imaging strategy. And then how do you determine what's winning? Which is the endpoint that you're measuring? Accuracy, segment by segment, clinical outcomes, patient-centered outcomes, and then, of course, the whole question of cost. This is one study done internationally, the PROMISE study, looking at anatomical versus functional testing for CAD. This analyzed CT angiography as the first test versus functional testing, stress imaging. And you can see over the 3.5 years of the study that there was really no difference. Patients had similar rates of events, which happened to be very low, whether you did an anatomical versus a functional test initially. If you did an anatomical test with CT angiography, the rates of invasive angiography were much higher, but the clinical outcomes were not any different. They had higher rates of revascularization, higher rates of intervention, but and more invasive testing, but it didn't seem to translate into difference in clinical outcomes. This was done in Scotland, the Scott-Hart study, which did compare standard practice, which is usually exercise treadmill testing, versus CT. And this one did show a difference in a population with a high prevalence of coronary artery disease. And the authors of this study, which has since had follow-up studies, suggested that CT was a superior first test in this population. The important difference is that the first test it's compared to is largely treadmill exercise testing, which has limited performance. If you did a CT scan in a situation of an inconclusive functional test, it does still have a lot of prognostic information. So looking at different types of coronary lesions, ranging from non-calcified, non-stenotic atherosclerotic plaque versus calcium versus multivessel, etc. The more segments you have involved, so severe stenosis at the bottom has a much higher event rate than no coronary disease or non-obstructive plaque, etc. So although it isn't a functional test, the anatomical delineation provided by CT does give us a sense for the patient's outlook. Of course, you could predict prognosis through many other measures, including just standard risk calculators based on other clinical variables. So I did refer him for a CAT scan, a CT angiogram. The Agatston score, the calcium score, was 0. So had no atherosclerotic changes whatsoever, and no calcific changes whatsoever in his coronary arteries. No significant stenosis, minimal non-calcified plaque at the luminal, at the proximal diagonal first branch, causing less than 50% stenosis. So, okay, so you've done all these tests, and now what do you do? Well, the patient was delighted. He was like, "Oh, I'm so happy. I don't have coronary artery disease, and I'm fine. And this is all just getting older." And I said, "Well, you know, you do have borderline high blood pressure. You have high triglycerides, and you have a mild stenosis. Perhaps you should be treated with some risk factor modification." But paradoxically, the CT result led the patient to a sense of he was very happy, and he felt that he didn't have to take any medications. So yeah, so anyway, so we carried on like that, and then I was on call at Sunnybrook Hospital, and the hospital in Toronto, it has a big park around it, and he was out for a jog in that park one weekend when I happened to be on call, and so here's just so
6 weeks later.
literally 6 weeks later, he came in with a lateral STEMI. So, and here was his angiogram. So you can see there's an occluded first diagonal branch, and this was wired and stented. And so he had a high lateral infarct, and it happens to coincide exactly with where the CT scan showed a non-stenotic lesion. So, you know, of course, everybody, when a clinical outcome like this happens, it really puts into focus some of the original thoughts I had about, you know, the nature of atherosclerosis and the nature of coronary artery disease and its clinical manifestations. I'm not sure if this man's presenting dyspnea had anything to do with his diagonal stenosis. It wasn't limiting flow. He had objectively excellent exercise capacity. He had 2 functional tests, which did not show evidence of abnormal perfusion. But of course, you know, he did then go on to have an infarct. And so I guess the question is, maybe I should have done an angiogram at the beginning, but let's say we had done an angiogram. Would we have done anything about the diagonal branch?
No.
Oh, medical management. So again, this comes back to the popcorn kernels. Medical management can help turn down the heat and prevent the sort of stochastic clinical events, plaque rupture, thrombosis that can cause grief. So, you know, to conclude, this is just a show and tell brief conversation, hoping to show some of the controversies in the field. Exercise treadmill testing, stress echo, microperfusion imaging, and CT are all reasonable initial strategies in a patient with suspected coronary artery disease. And the choice should be informed by patient factors, local resources, and coronary risk can be estimated, but the events are always difficult to predict. It's like, you know, the survival curves that I showed with normal perfusion imaging, that's a general survival curve. There's still going to be some events within that cohort, and it's a humbling condition to treat. So integrating all the clinical data is necessary in formulating a treatment plan. So, you know, to summarize, we've looked at the 2 different fundamental phenotypes of coronary artery disease, the atherosclerotic fixed anatomical obstruction, which is often symptomatic and treated with vascularization and medical therapy, versus the plaque rupture phenotype, which is less predictable. Talked about some of the performance of the tests, the different types of information the tests generate, some of the clinical trial evidence, estimates of prognosis, and again, a humbling reminder that coronary artery disease is, well, it's easy to diagnose, but it's difficult to predict. So thank you for listening, and I'll open up for questions at this point.
Thank you. Any questions from the audience? Would it help to estimate the FFR via CT angiogram?
I'm aware that CT angiography, there's some software that can estimate myocardium at risk and flow reserve. One of my colleagues at Sunnybrook was interested in that. In my work thus far, I have not done that. The radiology group at my previous hospital did not offer that. I think that's an area of development. The technology for CT has been growing leaps and bounds. Some of the data that I presented here is a little bit out of date. So if there's anyone in the audience who's expert in the topic, I'd be interested to hear their perspective.
I wonder, Mark, if you could comment on the role of medical therapy, but do you need to have established that there is coronary disease to start pretty aggressive medical therapy, or is simply the suspicion as you go through these series of tests? Do you see what I mean? What,
Yeah.
you know, upping beta blockers, making sure they're on the NACE, you know, those kinds of things.
Well, back in the early days of CT calcium scoring, it wasn't unusual to receive referrals from when I practiced in Toronto, patients would go across the border to Buffalo to a shopping mall and come back with a CT calcium score. And so you'd say, well, what should I do? I said, well, you should do what you would have done before you had the CT calcium score, which is you should modify risk factors and live as though you do have coronary artery disease. On the other hand, if you then start following that thought process, you begin to treat lower and lower risk patients, and you run into a lot of pushback around primary prevention, and the role of statins in primary prevention is controversial, because as you dilute out the risk, you start treating more and more people with more and more drugs, with more and more side effects and more cost for a diminishing clinical return. Beta blocker, for example, there's very little evidence that beta blockers can help if you have preserved LV function and no symptoms. There's not really much evidence that they're helpful in preventing cardiac events, and there's side effects. It's a complicated. There's no straight answer for this question. It's a dialogue between the patient and the provider. I have to say, in this particular instance, the CT angiogram actually dissuaded the patient from taking any medications. So it's kind of a paradox. Anyway, on the other hand, there is clinical evidence that CT angiography, kind of like on the lines of what I was alluding to, if it does demonstrate burden of atherosclerosis, then there is some evidence that can help to tailor therapy to the patients for whom it will benefit the most. I think that has promise, and I've definitely used that clinically in my own practice to try to help make a case for why preventive therapies would have rationale, even in somebody who's not symptomatic.
Your case is interesting, and there's an entity that's sort of ignored by most interventionalists everywhere, really, certainly in Canada, and that's microvascular dysfunction. So I know Steve Miner in Ontario does some invasive testing looking for those cases in these patients who don't have severe disease and have clear sounding ischemic symptoms. Often they have cardiographic changes on stress testing in spite of non-obstructive disease. And they'll go farther and do farther invasive testing to look for microvascular causes. So we don't really know the underlying cause of this guy's symptoms outside of the STEMI, but it's an interesting group of people. Most of us don't do that kind of testing. I think Steve's the only one in Canada. There's a few people in the US who do it. So it's very time consuming from cath lab resource.
That's Steve Miner. He's at South Lake.
I think so, yeah.
Question from Ron Bourgeois.
Yes, thanks. Excellent review. I just wanted to comment on the risk factor modification. If we use the lipid guidelines and look at the CT the patient had, a score of 0 is not predictive of 0 events, and they really clarify that and focus on that. We can't reassure them, as you mentioned, that the risk is 0. And I think, as you also mentioned, as soon as we see a plaque, they should be treated with the treatments that you said, despite the fact that we will get some pushback. I think some patients may be convinced once they do a plaque of whatever percentage, we know the less severe plaques are sometimes prone to rupture, more likely than the fibrous ones. And anyways, just a comment more so than a question, but thanks again for an excellent presentation.
You're welcome. I did present this at a educational event in Toronto, and I presented the case, and I was forthright, and the sequence that's presented here is the actual sequence. There's nothing here that's been conveniently edited, and I think there was one shout of malpractice when from the audience. So hindsight's 2020, and I show this case not because anecdotal medicine is scientific approach, but if you combine the anecdotal experience with the clinical trial evidence, I think it is helpful to remember that coronary artery disease remains a humbling disease, because even with extensive evaluation, even with medical therapy, there are still going to be events. And so just in communication with patients, I always am reminded of the importance of patients being informed about what symptoms to watch for, and a reminder that coronary atherosclerosis is a lifelong condition that's treatable but not curable. And we sometimes lose sight of that. And of course, most of the time, the sequence would have amounted to nothing because the patient's 30% diagonal plaque would have remained dormant. But anyway, this case, I think, does bring into focus some of the challenges that we face. Well, thank you very much. I appreciate the interaction and glad to be here in New Brunswick and look forward to working with you all.
Thank you so much, Mark. Thank you for your presentation and excellent discussion. Thank you. And I will finish recording and we will meet on our next rounds. Thank you. Bye.
Thank you.